Good evening, everyone. I am Arpita from the IGCP group. A warm welcome to our very special webinar on Beyond Intraocular Pressure, Real-World Glaucoma Cases in Clinical Practice. It's organized in observance of the World Glaucoma Week. Now, we are very privileged to have with us a esteemed panel of experts from the Rajan Eye Care Hospital, Chennai, who bring with them a wealth of experience and clinical expertise. It's an honor for me to first welcome our speaker moderator for today's session, Dr. Archana Nivas ma'am, who has done MBBS, DO, DNB, FAEH. She is a consultant at Rajan Eye Care Hospital, Chennai. And we have with us two speakers from the same hospital, Dr. Priyadarshini ma'am. She is MBBS, MS in Ophthalmology, Glaucoma Fellow at Rajan Eye Care Hospital. And we have with us Dr. Shubham B. He is MBBS, NBEMS DO, and he is a resident at Rajan Eye Care Hospital. So with this very brief introduction, Archana ma'am, now I will request you to please start with the session. Over to you, ma'am.
Good evening, everybody. At the outset, I would like to thank the IJSAP group for giving us this opportunity, and also our mentors, Dr. Mohan sir and Dr. Sujata ma'am, for giving us this chance to highlight their cases. So as we all know, this week, that is from March 9 to 15, is being observed as the World Glaucoma Week. So World Glaucoma Week is an initiative taken by the World Glaucoma Association. It is a global initiative that they have taken to bring awareness about glaucoma, which is as we all know, it is the leading cause of irreversible blindness worldwide. About 74 million people or more are affected by this disease, and most of them are asymptomatic. And about 10% of them they have a significant blindness also, which cannot be cured. So to bring awareness about this silent thief of sight, this week is observed as the Glaucoma Awareness Week. And so the goal of that is to make patients aware and to encourage them to get their eyes tested so that we will be able to pick up this disease early and give them the appropriate treatment. So today, instead of having a didactic lecture, we have decided to highlight two cases which are pretty interesting, which we have seen in our clinical practice. The first is that of a young, vibrant male who had no disease in his eyes to begin with, but he had an injury when he was playing badminton, and due to that, he developed glaucoma along with other problems. So it was a complicated case, and we have managed it effectively and sorted it out for him. The second case is that of a normal tension glaucoma, which is a very difficult type of glaucoma to diagnose because like any other glaucoma, there are no symptoms. And even the intraocular pressure, which is usually high, is also within the normal range in these patients. Many doctors, even ophthalmologists, find it challenging to diagnose normal tension glaucoma. And this case, that is why we took the heading of this session as beyond intraocular pressure, just to highlight the other factors which might be involved in causing this disease. So without further ado, I'd like Dr. Priyadarshini to present her first case, that of a traumatic glaucoma. Over to you.
Yes, ma'am. I'll share my slides.
Yes, sure, ma'am. Go ahead.
The screen visible, ma'am?
Yes, visible. Please make it a full screen.
Yeah. So good evening. Thank you for this opportunity. I'm Dr. Priyadarshini, Fellow in Glaucoma from Rajan Eye Care Hospital. Today I'll be talking about a case of traumatic glaucoma. So this is a 40-year-old male who came to us with a alleged history of shuttlecock injury in the right eye, which happened few months back, and he came to us with complaints of blurred vision in the right eye. And he also consulted elsewhere previously, and he was given certain eye drops, which was prednisolone eye drops. He was using 6 times daily, and dorzolamide with timolol combination eye drops 2 times, netasudil eye drops once at night, and nepafenac eye drops thrice daily. And he had no systemic illness and no other general illness and systemic examination was normal. On ocular examination, his right eye BCVA was 6/9. Eyelids was normal. There was a mild congestion in the conjunctiva. sclera was normal, and cornea, there was a nebula corneal opacity in the paracentral region, no pigments on cornea. Anterior chamber was quiet with a VH grade 4, and in iris there was a sphincter tear with a mid-dilated pupil. There was an anterior subcapsular cataract, which is a traumatic cause, and there was lens subluxation, which was noted at 4 clock hours inferotemporally. And this is the slit lamp image of the right eye, and here this is a retroillumination of the right eye, which we can see there is a PC, posterior capsular dehiscence. Left eye was absolutely normal with a visual acuity 6/6, and applanation tonometry of the right eye was 31 millimeters of mercury, and left eye it is 17 millimeters of mercury. And gonioscopy with 4-mirror gonioscope, it was ciliary body band was seen in all the 4 quadrants with 360-degree angle recession noted in the right eye. And in the left eye, it was scleral spur seen in all 4 quadrants. Dilated fundus examination of both the eyes was absolutely normal with a clear media, CDR, which is a cup disc ratio of 0.3, and macula was normal, and retinal periphery was also normal. With this, we came to the diagnosis of right eye traumatic glaucoma, and he was treated and he was started on brimonidine with timolol combination eye drops twice daily, and brinzolamide eye drops thrice daily, and oral acetazolamide twice daily. And since he was using prednisolone 6 times, we tapered him to 4 times daily since the AC was quiet. And on further follow-ups, his intraocular pressures was not under control, and he had recurrent attacks of inflammation, and we couldn't even start prostaglandin analog because it can aggravate the inflammation. Since IOP was also not under control, and the cataract was also progressing, and the cup disc ratio was also progressing from 0.3 to 0.65 in few months, and we planned him for phaco trap with mitomycin C. So this is a surgical video where you can see this is a femtolaser assisted capsulorhexis with the fragmentation of the nucleus being done previously. And after conjunctival peritomy, we are starting the scleral flap for trabeculectomy, which is a partial thickness triangular flap of 3.5 mm size. And mitomycin C has been placed. And mitomycin is very, very needed in traumatic cases because there is high chance of bleb scarring. So it is mandatory, and phacoemulsification is done now. Hydrodissection. And the phacoemulsification is being done now. So while doing cortex aspiration, we found a zonular dialysis here, as you can see. As you can see in this picture here, you can see there's a zonular dialysis. So we removed the phacoprobe carefully with the viscoelastic being injected, and we placed a capsular tension ring so that the zonal stability is maintained. So this is a capsular tension ring to maintain the zonal stability of the capsular bag has to be maintained. So we are putting this. And a 3-piece IOL is being placed. And the IOL was well centered. And we are proceeding with the trap. AC entry is being made now. And for the sclerostomy, we are using the Kelly sponge to make an opening, and peripheral iridectomy is being done. And we are checking the formation, the bleb, and we are suturing the scleral flap. Three sutures have been placed in the scleral flap. So now we are checking the AC formation, and AC is also formed. So we are closing the conjunctiva with a pursing suture. and everything was fine. And see, this is being tested now, and there is no leak. So after the tab, the initial follow-up, the bleb was diffused with the nice cystic spaces and the IOP was 20 millimeters of mercury. But on further follow-ups, the bleb became shallow and the IOP was also high. We did a laser suturolysis and it could be steroid response also. And there was some mild vascularization also started and we gave 4 sittings of 5-fluorouracil. And on ASOCT, it showed a shallow bleb with a minimal scarring of the bleb. So we tried bleb needling. Post-bleb needling, the bleb was diffused with IOP 12 mm of mercury and no AGM was given. And on further follow-up, there was an onset of cystoid macular edema. For that, we gave Nevanac. And then on the last follow-up, the IOP was maintained, CME was reduced, and the cup disc ratio was also maintained. So this is a case of a traumatic glaucoma, which is nothing but a type of a secondary glaucoma that usually follows after blunt or penetrating ocular trauma. And in blunt trauma, it could be early onset or late onset. In early onset, it could be mainly because of the trabecular meshwork disruption or hyphema or iritis. Whereas late onset, it is angle recession or ghost cell glaucoma. It can also occur because of chemical injury, radiation injury, or electrical injury. And we have to carefully look for conjunctival laceration, corneal laceration or scar, sphincter tear, iritis, iridodialysis, iridodonosis, osseous ring in the lens capsule, phacodonosis, lens subluxation or dislocation, hyphema, and in gonioscopy, we have to carefully look for the widening of the ciliary body band and cyclodialysis cleft. So this patient is most probably because of the angle recession glaucoma, where there is a tear between the longitudinal and ciliary muscles of the ciliary body happening, which can lead to the angle recession. And the initial IOP spike is most probably due to the damage of the trabecular meshwork and Schlem's canal, whereas the long-term scarring and fibrosis of the trabecular meshwork and Schlem's canal can lead to the elevated pressures down the road. So to conclude, angle recession glaucomas are very difficult to control medically and surgically than other types of glaucoma. But trabeculectomy with mitomycin C have been shown to be successful in lowering the IOP. But in traumatic glaucoma, there is a high risk for bleb failure because of the scarring. And the patient have to be counseled adequately and follow-up examination is must and it should be performed regularly. Thanks to Dr. Sujata ma'am and Dr. Archana ma'am for the video and thanks for the opportunity.
Dr. Priya, you can stop sharing your screen. Yes. Thank you. That was an interesting case. So I would just like to highlight a few points that it is a complicated case with multiple problems. Like there was a traumatic cataract, there was zonular dialysis, there was also a sphincter damage and pupil was distorted. So all this apart from the rise in intraocular pressure. So we were able to address most of the problems in one single surgery itself. What is important is we have to pick up all this very meticulously so that we know what to expect during surgery. And counseling the patient is also extremely important so that he knows that this is not an easy solution and following up is extremely important. So the patient was aware that it was not an easy road for him. And also carefully looking of, even after the surgery, the job is not done. Especially people say that for glaucoma surgeries, the amount of work that goes after surgery is equally important. We have to follow them up. And for us, for the glaucoma surgeries to work, postoperative visits and management is extremely important. And in this patient, we were able to pick up the changes that happened in him early, like the bleb getting scarred, which is highly expected in this patient. And also he developing inflammation in the macula. All these are changes that we need to look carefully for. And if we pick them up early and treat them appropriately, then the outcome will be extremely rewarding. So it is not an easy solution. Glaucoma is not a disease which can be easily treated unlike cataract. But if we are meticulous about it, the chances of success are extremely high. And in any case, we can prevent blindness for sure. So that is what I wanted to highlight. So with this point, let's move on to the second case, which is that of a normal tension glaucoma. Over to you, Dr. Shubham.
Yes, ma'am.
Good evening, everyone. Myself, Dr. Shubham. I'm a second year resident in Rajan Eye Care Hospital. Today, I will be presenting a very interesting case of normal tension glaucoma. So, a 62 years old female patient came to the outpatient department for a regular checkup with no specific complaints as such, but there was no history of colored halos, no history of watering, pain, redness, headache, no history of previous trauma, acute blood loss, or major surgery, no history of use of any kinds of steroids or any forms, no history of sleep disturbances or cold hands or extremities also. The past history, she is a known case of hypertension and on treatment tablet amlodipine 5 milligram once daily at a bedtime. There was no significant family history. Personal history, she was not a smoker and alcoholic also. General examination, patient was conscious, oriented to time, place and person, cooperative and well built also. No history of no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy and no edema also. In systemic examination, pulse rate at the time of presentation was 82 per minute. Blood pressure was 140 by 90 millimeter of mercury at the time of presentation. Cardiovascular system, respiratory system, per abdominal examination and central nervous system examination was within normal limits. In ocular examination, head posture was normal, facial symmetry maintained, eyes were orthophoric, isotropic, extraocular muscles movements were full. Vision with Snellen's chart, best corrected visual acuity in the right eye was 6 by 7.5 with plus 1 diopters per year and plus 1.25 diopters cylinder with at 170 degree. Left eye was 6.6 with plus 1 diopters per year and plus 1 diopter cylinder at 5 degree. Both eyes having near vision of N6 with plus 2.5 diopters per year add. In slit lamp examination, lids, conjunctiva, cornea were within normal limits in the both eyes. In the both eyes, anterior chamber was graded as a 3 von Erichs depth with quite anterior chamber. Iris color and pattern was normal. Pupil were round, regular, and brisk in both eyes. Lens status as a nucleus sclerosis grade 1 in both eyes. Applanation tonometry was done at 12:20 p.m. with Goldman applanation, and it was 15 millimeters of mercury in the both eyes. So on gonio, 4-mirror gonioscopy was done and graded by Schaeffer's grading. In the right eye, posterior trabecal meshwork was seen in 3 quadrants and 1 quadrant scleral spur. Left eye, there was a 2 quadrant scleral spur with 2 quadrants posterior trabecular meshwork. In dilated fundus examination, media was clear. This is right eye with clear media, disc normal in size, vertically oval. Margins were well defined. We can see there is a bipolar notch also, and there was no evidence of disc hemorrhage. So CD ratio we can see as a 0.9 with bipolar notching here. With we can see there is a clear-cut RNFL defect also inferiorly. In autofluorescence in the right eye, we can see there is a clear demarcations and superior and inferior wedge defects also we can see here. So dilated fundus examination in the left eye, media was clear, disc was also normal, disc was normal in shape and size, but there was an inferior notch with 0.8 cupping and AV ratio was within normal limits. This is the disc of left eye showing inferior notch prominently with the inferior defect also. In autofluorescence, we can see there is an inferior wedge defect clearly. And on OCT, optical coherence tomography of retinal nerve fiber lesion, we can see both eyes in statistic raw data of RNFL thickness map. We can see there are cool colors, which is noting right eye is superiorly and inferiorly more, and in the left eye there is inferior thinning more. So RNFL deviation map, we can see there is a thinning in the right eye superiorly and inferiorly with the red demarcations. In the left eye, we can see there is more thinning in the inferiorly with the red demarcations. We can correlate all this with the RNFL thickness maps here in the quadrants and clock hours also. So we proceeded with the fields in the right eye. That is, this is the field of right eye with a single field analysis, central 24-2 threshold test. We have done this in CETA standard strategy with stimulus of 3 size with white background. This test was actually came less reliable since there was loss of fixation, but because of high suspicion, we have done another test with right eye single field analysis, central 10-2 threshold test. with Sita standard and third 3 as a stimulus size with white background, which is a pretty good reliability. We can see there is a central involvement also in the pattern deviation maps with superior arcuate defect. This is the left eye showing superior arcuate defect, and this is a good reliable fields also. So phasing was done this for this patient in the both eyes, and it came negative. Central corneal thickness was 582 and 589 microns. So my final diagnosis is normal tension glaucoma in both eyes with nuclear sclerosis grade 1. We started the patient on latanoprost eye drops, that is prostaglandin analog at bedtime for both eyes. We called this patient after 1 month to check for the progression and for the close follow-ups, so that we can see there is any progression and we want to change any drops or anything to be done. So next visit, we are planning for complete blood reports with inflammatory markers, carotid Doppler and ECG also. I will talk about this in a short time. So to discuss this very interesting case of normal tension glaucoma, NTG is also referred to as low tension or normal pressure glaucoma, which is usually regarded as a variant of primary open angle glaucoma, which is characterized by intraocular pressures consistently equal to or less than 21 millimeter of mercury. Since in primary open angle glaucoma, the pressures will be high. Signs of optic nerve damage, which is characteristic glaucomatous pattern, and visual field loss as damage progresses, which will be consistent with the nerve appearance of the fundus examination also. The anterior chamber angles will be open. So to distinguish NTG and primary open angle glaucoma, the IOP will be normal, but in POAG, IOP will be high. So risk factors, patients tends to be older than those in POAG. Females are more common in Japan. 90% of people are around 90% people are affected with this disease. There are some mutations also like optonurin gene, myocilin gene, and tank binding kinase 1. There is a central corneal thickness will be lower than primary open angle glaucoma patients. Abnormal vasoregulations, migraine, Raynaud's phenomenon. Raynaud's phenomenon means there will be cold hands and extremities also. Hyper and hypotension also is a big risk factor for normal tension glaucoma. We have to check the sleeping habit of the patient also, like snoring or anything else, so that we should rule out obstructive sleep apnea. All these abnormal vasoregulation systems things will actually decrease the perfusion of the optic nerve, so it will cause progression of the glaucoma. So clinical features: long-standing headache, migraine, Raynaud's phenomena, medications like systemic steroids of any kinds or any forms, or beta blockers. Beta blockers, why we are thinking about it is it will mask all the systemic features of the disease. IOP in previous episode should not be high, so we have to rule out primary open angle glaucoma also. Optic nerve head changes that we have seen already. Visual field defects will be more localized than primary open angle glaucoma and central threatening. So in this case, in this patient also we have seen there is a central threatening visual field defect, and mostly non-progressive for 5 years, even without treatment. So we have to keep a close eye on these patients. We have to rule out any neurological lesions. So in neuroimaging, we will see there is a vertical obeying of the meridian, and other investigations to think are blood pressures. Why we are checking blood pressures now? Hypotension people are more prone to cause normal tension glaucoma. There is a study which noted them as a deepers also. Deepers in the night, there will be a low BP, which will cause less perfusion of the optic nerve disc, and it will cause glaucomatic changes. Blood investigations for non-glaucomatic optic neuropathy, carotid Doppler, and ECG also. In management, it is almost as same as that of other glaucomas. Plus, we can consider yoga, but not head bending exercises, mild exercises, and meditation. Medical treatment is almost same as that of other primary open glaucomas, but neuroprotective element is there. There is brimonidine, betaxazole have already like we already know it's they have neuroprotective thing. Neuroprotective agents, there are memantine, nitric oxide synthase inhibitors, calcium channel blockers, immunomodulators, and antioxidants, which are in experimental stages. So my take-home messages will be to diagnose NTG. This is a diagnosis of exclusion. So we have to rule out any other cause of which will cause these things, which is nocturnal hypotension, vascular dysregulations, carotid occlusion diseases, or we have to rule out any other secondary glaucomas also. So structural damage precedes functional loss. So OCT RNFL thinning detects even before fields detects. So visual field defects will be seen only after 40% of damage has already been done. But OCT RNFL will take it up before itself, so we can do OCT RNFL in such patients. Monitoring progression can occur despite normal intraocular pressures. So we have to look for visual fields, we have to do OCT scans and disc photography for progression of the disease. Systemic factors, sleep apnea, migraine, Raynaud's, low BP, we have to look for. IOP management is almost same, but we have to individualize the patient's target IOP, and we have to reduce it till 30% of the baseline IOP. Treatment strategies are almost same as that of POAG plus neuroprotective and vascular optimization. So these are my take-home messages for this interesting case, and thank you for this opportunity.
Thank you, Dr. Shubham, for the good presentation. So I would like to just highlight a few points in normal tension glaucoma. So as we all know, in the pathophysiology of glaucoma, it is believed that it is the increased intraocular pressure which damages the optic nerve. But this entity proves to us that apart from the intraocular pressure, there are non-pressure dependent factors, especially the ocular perfusion, which can have a role in deciding whether that particular optic nerve head will undergo optic atrophy, glaucomatous type of optic atrophy. So ocular blood flow is dependent on a lot of factors, the main thing being the blood pressure and other auxiliary factors. So patients who have normal tension glaucoma, they do not have completely low intraocular pressure, but they have pressures which are within that 20 millimeter mercury mark. So the normal pressure is a statistically derived range. 10 to 20 is what statistically most of the people have. So these people have it more in the higher teens. And it has been found out through various studies that even in the so-called normal tension glaucoma patients, reducing the intraocular pressure has a beneficial role. In fact, that is the most effective means to manage the disease. So that is the rationale behind reducing the pressure, though it is within that 20 millimeter mercury mark. So for these patients' eyes, even that pressure is sensitive. Their optic nerve head is sensitive to even the so-called normal pressure. That usually because of some kind of autonomic dysregulation that is seen in these patients. So that is a theory that has come up in the recent past, and authors have described two kinds of normal tension glaucomas. So one in which we actually just pick up a one-time damage. So there might have been an event like an acute blood loss or a nutritional deficiency, which might have caused the damage to the nerve, which looks very similar to a glaucoma, but it's a static phenomenon. So that is one subtype of normal tension glaucoma patients. So there is another subtype of patients whom the damage is characteristically progressive, despite them having the normal intraocular pressure. So in these patients, it is the vascular factors which are blamed at. So this kind of disease is more common in females because they have a higher chance of having systemic hypertension as well as hypotension and migraines and Raynaud's phenomenon, where we see that the extremities get cold and it gets discolored, it becomes blue in color. And they also have, like I said, low blood pressure. And there is also a syndrome which has been described by a few authors in Japan. It's called the Flammer syndrome, where patients have extremely low blood pressures. They have a decreased awareness of their thirst, and they are more prone to systemic hypotension and normal tension glaucoma. So that is an association. Other factors which we have to look at is things like sleep apnea syndrome, which again, as we know that there is a functional obstruction to the airways, which happens because of that laxity which is there in the laryngeal area. So these patients snore a lot. They have daytime somnolence. They feel tired all the time because though they sleep, the quality of their sleep is not good. So these patients, we do have patients who come up with that characteristic symptom. So we have to refer them to a sleep specialist where they do a study, and many of them are put on CPAPs. So that has an indirect role in controlling their glaucoma as well. So that is the role of sleep apnea syndrome in normal tension glaucoma. As far as the neuroprotection goes, so neuroprotection is still, it's an evolving entity. Few glaucomatologists say that decreasing the intraocular pressure is the most neuroprotection that you can give to the nerve. So they say that brimonidine, for example, brimonidine has a neuroprotective effect mainly because of its ability to decrease intraocular pressure. It's a controversial topic. So, and we have also seen from our experience that many of these patients, they are vegetarians, they have B12 deficiencies. Some of them have even vitamin D deficiencies. Vitamin D deficiency is something which is very rampant. So we do put these patients on vitamins, which include B12, and also give them calcium. So that has a protective role in many patients. So another ancillary investigation that we can do to indirectly look at the optic nerve head perfusion is the Doppler studies. So Dopplers of the optic nerve head can be done. It is not a very widely available investigation, but there are a few centers who do it. So they look at the perfusion pressures, the resistive index. So these give us an indirect idea about what is the resistance there is to the blood supply to the optic nerve head, and we have to work in tandem with the physicians to see whether we can modify it. The simplest thing that probably we can do is, if the patient is taking a blood pressure lowering agent in the night, so it can be modified to be taken in the morning time or in the afternoon time, so that the perfusion that happens at the level of the optic nerve head is not reduced. So that is the simplest thing that we can do. And apart from this, checking for hemoglobin status, checking whether the heart's ability to pump blood, the echo is good, and then the carotid Doppler of the carotid arteries. So these studies also have to be considered as far as the systemic investigation goes, to make sure that those are not aggravating the condition. And as far as the eye point of view goes, another thing, like in this case, is we did a diurnal variation testing. So where whether we see whether the fluctuations are too much for the optic nerve head to handle. It might be in the normal range, but it might be too drastic. So that itself can insult the optic nerve head. So the diurnal variation testing has a role. And there are a few anti-glaucoma medications like dorzolamide, which blunt the effect of these variations. And even if the patient misses 1 or 2 drops, still the intraocular pressure is maintained. So these kind of medications, especially dorzolamide and brinzolamide, they have a role in normal tension glaucoma. So that is about the scientific, the clinical part of it. For general ophthalmologists, so I would take this opportunity to highlight the fact that the second patient, their vision was almost near normal. So in the vision testing chart, he was able to read almost till the last line. But only when we do the visual field testing, because we had the suspicion that there is a problem, that we could make out that there is a quite a significant visual field defect. So this patient does not have any symptoms, but he had at least a moderate amount of glaucoma, which need to be detected. And though the pressure is normal, yes, it does require treatment. So I'd like to highlight that point, take this opportunity to highlight that point. So yeah, I think that is the end of the discussion.
Right, ma'am. Thank you. Thank you so much for concluding it so nicely. And thanks to both our speakers. And ma'am, we have received a few questions from our audience. Shall we go ahead with them?
Sure.
So, first is from a general public perspective. The question is, glaucoma often progresses silently. So, what symptoms should individual be aware of to seek timely medical attention?
So as the person rightly pointed out, there will not be any symptoms, because unlike high blood pressure, which can cause headache or dizziness, high intraocular pressure usually in 90% of the patients doesn't produce any symptoms. So only when we measure it, we find out that it is much beyond the higher range. Even there are patients who come up with pressures of 30, 40, but they do not have any symptoms. But there are patients who do have symptoms. They feel that they have fluctuating vision. They feel that sometimes their vision is blurred, sometimes spontaneously it becomes better, or they might have headaches which they cannot account to anything else. Headaches that occur frequently associated with blurred vision, vomiting sensation. So these are all some subtle signs of the eye pressure being high, but there are no characteristic signs to say that if this is it, this is the pressure. So mostly it is asymptomatic. So only when we get an eye exam done, usually we will be able to pick it up, apart from the non-specific symptoms that I just mentioned.
Right, ma'am. There is one question. I guess it's from an ophthalmologist. The question is, how do you approach glaucoma management in patients with multiple ocular comorbidities such as diabetic retinopathy or uveitis?
So again, it depends on the grade of the other disease. So diabetic retinopathy, it has various grades. So it has to happen in tandem. So diabetic retinopathy treatment and treatment for glaucoma has to happen in tandem. So there are a few modifications, like certain drugs which we would not use in patients who have diabetes. Use prostaglandins. That is just an example. So depending on the grade, suppose the patients have a diabetic retinopathy which is very advanced, and we have a whole spectrum of patients. So where the diabetic retinopathy is more severe and the glaucoma just it's a mild glaucoma or a moderate glaucoma, so that can be managed medically. So if it is the other way around, let's say that the eye pressure is extremely high, so that has to be looked up at front, because as we all know, glaucoma is irreversible. Diabetic retinopathy, at least we have options to set it right. But for glaucoma, once the vision comes down, it's very difficult to get it back. So uveitis, again, uveitis has a lot of etiologies. So depending upon the cause, that is addressed early enough, the etiology into an advanced glaucoma, because uveitis at its early stages, usually it only causes a intraocular pressure spike and doesn't have any residual effect on the angle. So if we pick it up at that stage, then the uveitis is manageable. I mean, the glaucoma part of it is manageable.
Right, ma'am. There is one query, that is, with evolving surgical and medical treatment options, how do you decide when to do a transition from pharmacological management to surgical intervention?
So one is based on convenience, I would say, because many, if not most of our glaucoma patients, they present at around 60 years or more, and mostly they have some amount of cataract. So many of them, so for the patients who have a significant amount of cataract which requires surgery, and if their glaucoma is significant, it's moderate or severe, then we take that opportunity when we do cataract surgery to address the glaucoma as well. So now we have less invasive options like minimally invasive glaucoma surgeries, which is almost like just doing a cataract surgery, except that additionally, you will have a few millimeters of mercury drop in their pressure. So while doing a cataract surgery, I would plan for a glaucoma surgery. If it's a severe form of glaucoma, then I would do the trabeculectomy. We'll do trabeculectomy. If it's a mild to moderate glaucoma, then the option of MIGS is. So that is one time when we treat the glaucoma patients surgically. So other time is, of course, when the glaucoma is very severe and the pressure is not coming under control with various medications, or they are not tolerating the medications well, or they cannot afford to, buy medications and use it recurrently on a regular basis, then we offer surgery for such patients. So, but we would not jump in and do surgery unless it's really needed.
Right, ma'am. So surgery is the last resort.
Yeah, mostly, but now we have less invasive options. So when we are planning for a cataract, then we can plan for glaucoma surgery also. Okay, that option is there.
Right, ma'am. There is one last query. This is from our public, and this question is for Dr. Priya and Dr. Shubham. So, are there any lifestyle modification or dietary habits that can help in slowing the progression of glaucoma? Dr. Shubham and Priya, if you'd like to answer.
So actually, there is no lifestyle modifications. Maybe some smoking habits, if they have, might be having some association with glaucoma. So other than that, we don't have any other lifestyle modification. And maybe systemic blood pressure and diabetic control also has to be there, so that the progression is not too much.
Right, ma'am.
As
Right.
she rightly pointed out, yes, smoking and drinking have a definite role in progression of glaucoma because they affect the nerves all over the body, including the eye. And it has been found that eating green leafy vegetables, they have phytates in them. So that has some amount of neuroprotective effect. Apart from that, a healthy lifestyle, keeping the blood sugar and blood pressure normal, regular exercises, doing meditation exercises, it has a role in management of glaucoma. It can keep it under control.
Right, ma'am. Ma'am, before concluding, I would like to take the take-home message from the three of you. So, any tip to keep our eye healthy? Anything, not related to glaucoma only, but anything, ma'am. So, starting from Dr. Archana, then we'll go to Dr. Priya and Dr. Shubham. Yes, ma'am.
Yes, so yeah, having a healthy lifestyle, I think that is the first thing I would do. And specific for the eyes, go for vitamin A rich foods, go for different colored fruits and vegetables because they are rich in phytates and other antioxidants, and go for foods which are rich in omega-3 fatty acids. They are all good for the nerves of the eye. And things like flax seeds, they have a role in reducing the eye strain that happens because of dryness. So that is for the eye health. And apart from that, limit your screen time as much as you can. I know that we are all living in a digital world where for each and everything we look at devices. But if it's possible, we should reduce our screen time. And also, I think after 6, if possible, reduce your screen time because that it has an impact on our circadian rhythm and the quality of our sleep, etc. So I think that is important for the eye health as well. And of course, apart from the regular opthal examinations that have to be done.
Thank you so much, ma'am. Dr. Priya and Dr. Shubham, anything you would like to add?
No, ma'am has told almost all.
Right. Dr. Shubham, anything from your end?
Nothing, just lifestyle changes now. Mostly we have to reduce the screen times and all because it's very common that computer vision syndromes are everything, and dryness and all those things are very common nowadays. We are seeing very commonly the dryness symptom is there. Itching, irritation, redness, all this most of the times patient come with their dryness only. Other than madrasa and all that has come down in
Especially
after COVID.
post-COVID.
Right. But sir, the kind of work that we do, it's nearly impossible to reduce the screen time.
Yes.
So what can we do to prevent our eyes, sir?
So in which there is a 20-20-20 rule. So we have to do work for 20 minutes, take a break of 20 seconds, and wait for another 20 seconds, and you can again work for 20 minutes. So like that, there are some things we can do for regular working times also.
Blinking has to be more.
Yeah.
Frequency of the blinking.
Blinking rate has to be increased. We have to take breaks in between. Use lubricants.
So the visual hygiene, the ergonomics of the work situation has to be good. What light we are seeing and
correct.
Right. Thank you so much. So as we wrap up this insightful session on beyond intraocular pressure, I would like to thank everyone for joining in, and a heartfelt thank to our speakers for today, Dr. Archana, Dr. Priyadarshini, Dr. Shubham, for sharing their valuable expertise and real-world case insights. Your contribution has made this session truly enriching, and thanks to all our audience for their engagement and thoughtful questions. So, with that, I would like to thank all of you for joining us today, and we look forward to seeing you in future sessions. Stay informed, stay vigilant, and take care of your vision. With that note, I would like to conclude for today. Thank you. Thank you all for joining.
Thank you.